So we are just about 30 seconds early here, but I'm going to go ahead and start us off. I see we have a few people joining us already. Thank you so much for joining. Welcome to CalHIPSO's monthly webinar series. All attendees are currently muted. However, we do hope to open the platform for discussion during the presentation. In the meanwhile, should you have any questions, please enter them in either the Q&A or the chat box that you see available on your screen at any time. Today's webinar is being recorded. The slide deck that we're showing you and the recording will be made available on our website, calhipso.org, within a few days after the presentation. We will share a link to our website via email when the recording and slide deck are available for your viewing. And now we're going to have a short intro by CalHIPSO's Interim Executive Director, Deanne McCallan.
Hi, everybody. Thanks for joining us today. I'm glad you were able to make it. There's a few people on that I don't recognize their names, so that's exciting. And if there's anything further that you want to know about CalHIPSO, please reach out to us at the info@calhipso.org. We were founded in 2010, so 10 years ago, and we were brought together by the California Primary Care Association, the California Medical Association, and the California Public Hospitals and Health Systems. So in this time of COVID, I'm sure you're sure that these organizations have all been extremely busy helping the safety net in response to COVID. Next slide. A little bit of what we have been working on is the Medicaid Meaningful Use program. Medicaid Meaningful Use is still going. There's still an opportunity for eligible professionals to earn incentive dollars both with the 2020 and the 2021 program year. For a lot of folks, that has gotten lost in the haze, and there is some revenue that they could be making up for the loss during COVID that we're able to help you with. Our contract and other CTAP contractors go through September 30th, but the program is open beyond that. So if you want some technical assistance for Medicaid Meaningful Use, please reach out to us. You can just come to me, and if it doesn't fall under CalHIPSO, I'll spread the information to my counterparts with the other contracted companies. And also the Practice Transformation Support Services is another part that CalHIPSO has been working on this past year. We've helped clinicians earn more than $300 million in incentive and worked with over 15,000 clinicians. Next slide, please. And not to cut to the chase for missing out today's webinar, but don't forget we have a webinar every month, and this is some information on the next webinar. With today's presentation, we're continuing a string of presenters who have sponsored CalHIPSO's Interoperability Conference that was to be this May. Of course, it was canceled because of COVID, but we have enjoyed continuing the relationship with our sponsors and giving them a platform to be able to present because that was not available to them in May at our conference. So specifically today, we're joined by Protexa Healthcare's CEO and founder, Kishore Joshi, and also Jody Green, the Chief Growth Officer of Protexa Health Tech. With no further ado, I'll pass you off to Jody. Thanks.
Thank you. And I'm going to take the screen now, correct?
Yes, you can go ahead and take over screen control now.
Thank you. Protexa Health Tech is a company that Kishore founded, and I joined a couple of years ago. We're very excited to be here today, as Deanne had said, to tell you about interoperability, but also tie it into the very foundational things that are needed for that. And that's where we're going to talk to you a lot about Protexa IQ, the app that Kishore has developed. So I'm going to start with this. And pop quiz, anyone wants to answer, feel free. What do these two things have in common? You got a submarine on the left and a hospital on the right. Not going to keep you waiting, but it is the direct lead-in to Kishore. So Kishore, please introduce yourself.
Thank you, Jody, and it's great to be here with everybody at CalHIPSO and the participants. And as Jody just kind of introed, that was a nuclear submarine and healthcare. And believe it or not, I think that there's a lot of similarities. That's where I started my career, was in simulations, in nuclear submarines, in the event of a incident, shall we say, in case there was a nuclear incident. And in those scenarios, you needed data very rapidly. So fast forward, went on, worked with a number of different companies, and using that background of data, which is so important for decision making in various industries, ultimately landed me in the US and healthcare. Not that they're both heading for a disaster, but there's so much similarities for the need for that data. And more specifically as well, the need to capture that data in a very easy manner, which we are going to go through through this presentation. So that's a little bit about myself, and I'm going to hand back to Jody.
Thank you. Okay, I love the British, in case of an incident. Here we would say nuclear devastation, but you know, semantics, nuance.
Disaster, yeah.
Yeah, exactly. A little subtle there. And I'm the New Yorker, so we balance one another out here. Hello again, everyone. I, as I said, joined Kishore and his mission here, which I believe is doing well while doing good. We can really help everyone in the healthcare ecosystem, providers, patients, and others who participate, and really make a difference. So I come from a background, and my part of this is helping to think about the positioning and the branding and go-to-market. I'm a strategist. I have worked with over 20 pharma companies, large and small, globally, over 40 brands, med devices, pharmacogenomics, pharmacokinetics, all kinds of things, and with the largest global agencies. I'm also a knowledge consultant, often asked to advise Accenture and Boston Consulting Group and venture groups if they feel, well, particularly for VCs, is it a worthy investment in terms of health and wellness companies? Where are they with their technology, their innovation? How are they positioned in the marketplace? I'm also a board member and an advisor to many other companies, specifically in tech, to in AI, in voice tech and other things, because I, like Kishore, I'm excited about doing new things and bringing new things and helping people in that way. And the highlight of my career, honestly, was in 2011, well, two highlights, but one of them was in 2011. I was one of only 30 digital health experts in the nation invited to the White House to talk about how to improve information and access to care for women through a health summit, an online health summit. And one of my clients now, I'm very proud, is the United Nations, working on support for women and children and men who have suffered sexual violence at the hands of ISIS and Boko Haram and others like that. So again, it's that doing well while doing good, and Kishore shares that as well. So let's ease in with a moment of humor here about EHR interoperability, which we'll give fuller context to, but I think everyone can relate to this, where we are today. Not a lot of everybody playing well in the sandbox. How did we get here? Let's step back a minute. The Affordable Care Act came into play, $36 billion land grab. Everybody was out there, and quickly, you know, all the systems went out, and they were really designed for, you know, the administrations, so that it was billing and coding. That's really what these were, billing tools, and not really designed with providers who are using them, clinicians of all sorts. So that's the death by 1,000 clicks. Fortune covered it in 2019. I suspect you all know that. And at that time, everything that was written in the chart is now called data. That's where the word data is, because data is actually anything. It's information. It's not just numbers. People often hear data and think it's numbers, but it's words, it's sounds, it's images, it's videos, it's every text message on your phone. It's everything. And that brings us to interoperability, which is today's buzzword, and it's meaningful. I don't mean to say that in a negative sense, but it's taken us a long time to get here. and interoperability is simply exchanging information across different devices by different platforms. It would be as though your iPhone and your Android phone could literally share info, but they're proprietary, so that's not happening. And it's also referred to as data sharing, data unblocking, data liquidity, data portability. This all started, the reason I, oh, I'm sorry, go right ahead.
It's okay. So this is an interesting slide here as well. I'm sure some of our audience will relate to this because, you know, you can send, for example, in other industries, in manufacturing or supply chain or logistics and retail, or let's take finance, for example, you can send data around the world in seconds. And you don't really think about how it's being done or what are the tools or applications in the background. And it's just taken for granted that that's what you need to do. My background as well, you know, coming from an outside perspective into healthcare, it's so fascinating that healthcare, when people say it's slow to move, it truly is. And only now are we seeing these words like interoperability and sharing of data. Whereas the earlier slide that you put up there, the $36 billion later, 1,000 by, you know, death by 1,000 clicks, a lot of providers and clinicians will relate to this. I develop systems because there's money there. And every man and his dog will jump at it then to get a slice of that. Doesn't mean to say it's going to be usable by the end users. And then when you start rolling it out, everybody's going to put their hands up and say, hey, hold on, we can't use this. We can't work with this. And revenues decline and, you know, people get frustrated. And I know we got, you know, physician burnout, and you're going to talk about that a little bit later on. But it's fascinating to see this interoperability. I think for the first time in, I would say, at least 7 years, I've seen this now move so rapidly on the interoperability. And that may have been unintentional as a consequence of COVID. So just wanted to kind of point that out there, that the industry now in healthcare on the interoperability is really moving forward. And this is just kind of my outside of the, you know, kind of view kind of lens looking at it inwards into healthcare. Because when you're in healthcare, it's difficult to see everything. So I just wanted to kind of put those in there in that, because it was a great slide there.
Great context. And actually, it all started in 2004. So it's, yeah, and it's not really going to be done until 2025. So 21 years, but we're getting there. Yeah, I have a lot of quotes here. I'm not going to read them to you. This will be shared. But clearly, while proprietary companies would rather keep things siloed, and that's a good bet when you're doing that as a company. But the other side of those who are not having access is definitely an issue. That's finally, the government has spoken, it's law, but this debate rages on. Kind of a cat fight. You've got, you know, EHR company XYZ, ABCD, and you've got everyone else in the healthcare system, providers, hospitals, patients, caregivers, basically anyone other than an EHR company. But at this point, I'm going to have us back up a minute, because we're going to keep hitting on data, which is, again, information, notes, and the big push, the death by 1,000 clicks, is all because you can't easily capture the data. And that's the critical foundational thing. And this is exactly where Kishore started with nuclear subs. He was responsible as a strategist to create simulations to design both easy ways to capture the data for nuclear sub crews and to communicate it, and it had to be in real time. So again, little pause here. I think we can all appreciate, as Kishore said, and you all know, yeah, it's death by 1,000 clicks, not looking too good for the patient in this cartoon either. And usability, numerous studies. This is one of the latest. It's, I think it was March of this year, Mayo Clinic came out with an EHR usability study. As you can see by the arrow, so as not to be missed, EHRs scored an F. They are harder to use than Microsoft Excel, and I can't speak to others, but I'm not so great at Excel. But let's just say there's a chasm here, and it's not even like near to okay. It's clearly not good usability. And as Keisha said, and we all realize, we know that this is a leading cause of clinician burnout. It's extraordinarily time consuming. It eats up, on average now, 65% of a scheduled patients of a day of a provider is actually spent on documentation. So you know that part, but on the right, I don't know if everyone knows how at risk you really are as clinicians. In joining the company, I learned that those in your profession have a suicide rate twice the general population, 1 clinician per day on average. And actually it's really been skyrocketing due to COVID. It's very unfortunate. I'm here in New York, and one of the most respected EHR physicians 2 months in took her own life, and she was just devastated by what was happening and struggled to keep up with documentation being part of that. And for women, it could be as much as 60% higher chance of committing suicide than a male counterpart. Again, you know, it's being responsible for managing your home and your business.
So
And
on that
sorry.
slide there, yeah,
Yes.
I just wanted to kind of let the audience know as well that, you know, because we see this in our company. Obviously, you're part of, you know, on the inside, but I think I'm very fortunate to have a fantastic team that really are passionate about what they're doing in helping solve some of these issues, not just on the data, and we'll come on to that in a moment.
Right, that's true.
Consequences of this physician burnout. And, you know, there's like that in our internal saying, if we can save 1 physician's life,
yeah,
I mean, that in itself, it will save 1,000 other lives.
right.
And that's the kind of passion I see in some of our team members. So, you know, that with that and everything else that is going on in the post-COVID world and the issues that clinics are facing, I think this is the really good thing that the government has done in
Yes.
that opening up of the interoperability and the data portability. It's going to take a little bit of time to get there, but it's definitely now on the right tracks, I believe.
Yes, absolutely.
Good.
So, no, that's okay. And burnout actually at helping people, that's why I said doing well while doing, that's our North Star. We want to make a difference. We've all had job offers at other places. We don't want to make widgets. We want to do something meaningful, and that's something that I know Keisha and I have been stressing. So it's, yes, clinician suicide, and patient deaths. There are more than 250,000 people who die every year from medical errors. I've now seen more studies that say 440,000. And EHRs, study after study after study after study, are cited as a leading cause of patient harm and death. Just so many reports about this. And this is where, as Keisha said, I was going to add that if we can save 1 doctor's life, 1 nurse practitioner's life, 1 RN's life, 1 patient's life, that'll be amazing. But I agree with Keisha, exponentially, we know our impact can be far greater. And now we're built up to this, capturing the data, the quality of the data, what the heck do you do with all this data when you're sharing it? With that, I'm going to tell you, I'm going to introduce Keisha. We have created the first alternative to all of these issues with the HRs. And with that, it's over to Keisha.
Thank you, Jody. So one of the things that we have to do when you're looking at applications is you've got to make it Apple-like ease of use. At the same time, having it as a NASA level precision. And what we set out to do was address 3 major issues in the industry. The critically flawed data, which we are going to talk about, The unsustainable revenue losses. I mean, we're already in a post-COVID environment, and clinics are really, clinics, health systems, they're really hurting. And even before, this was even before we were in this COVID environment. And obviously, this unknown issue, except within some of the professions, is this catastrophic clinician burnout. It is absolutely amazing. So I, kind of roll it back again to the earlier days of the nuclear submarines. You've got to make it easy for the user to capture that data. Right? In the case of submarines, it's a crew. In the case of the healthcare, you are the crew. The clinicians, the MAs, the RNs, the nurses, the administrators, you are the crew. And if it's not easy to capture that data, you're not going to do it, right? So I'm going to
let me add something, if I would. When we say Apple-like, this is as easy as using your smartphone. It's touch, tap, talk. There's literally no learning curve, because it's also designed, when I say doctor design, this was designed by ER physicians. So this is literally not done as a billing tool. This is from a whole different direction of having doctors design it with the workflow of how you're trained in medical school, how you go through your entire process. And the ease and speed, there are people who are not at all providers who've been trained in medical school and literally pick this up in 10 minutes. And the other thing, the NASA-like precision, it does go to nuclear subs. And, we do, with the deaths I've talked about, Kishore has noted, there is no margin for error to die in space or a nuclear sub. And we believe the same applies to healthcare. We should reduce to as much as possible to eradicate that.
Okay, next slide, please. I know you're in the control seat there.
Here you go.
All right, so data, ones and zeros, right? As Jody mentioned before, so much of it is unstructured because it's coming in from different formats, different ways, typing, talking, videos. It's all unstructured at the moment. And I think a lot of people who are on this audience in healthcare, they understand that. What we need to move towards, and what the industry is moving toward, is more of a structured environment. What does that mean? It's the ones and zeros. Right? With the ones and zeros, you now have the ability to have actionable data, so you can run your reports and everything else, and do the things that you need, because that's what computing power does. They use ones and zeros. So next slide. How do
what? Before you do that, give your parking. Kishore has this brilliant parking lot analogy.
Oh, okay.
Yeah.
Yeah. So you kind of visualize this, that if you've got a parking lot and you've got cars in the parking lot, parked in all sorts of different ways and positions and angles, it's extremely difficult to get in and out. I mean, you can get there, but it's extremely difficult. Now you go to a structured environment where you got the parking lot, everything's in there, nice little kind of units, and you got the slots and people parking within those lines generally, right? It's now organized. You can now get to where you want to get to very quickly. You can get in and out very rapidly. So
and no accidents, no mistakes. Yes.
So that's the kind of analogy if you're thinking of how data is organized. So what did Protector IQ do on this data? Well, if you kind of look on the right-hand side at the top, this is the core of your data. You allow the clinician to capture it just by tapping on their tablet or PC, You tap once for a positive, tap twice for a negative. And there are thousands of anatomical diagrams that are already built in, so you don't have to bring those up. That's your ones and zeros. That's your ones and zeros. And we've got proprietary, touch tap talk technology. So now all the clinician needs to do is go through the anatomy, tapping through the positives and the negatives. And as you're doing it, you're actually capturing that data. It's designed in a way that is, Jody mentioned, it's a cognitive behavior, the way they were trained at medical school. So,
and because it works like a smartphone, it's intuitive for everyone. And also, you don't just have to tap the anatomy, you can. But I wanted to add that things are auto-completed because it's so precise in capturing things. So it's auto-completing the documentation and the coding because it's all captured in such a structured manner.
Absolutely. And, when you compare, because we're in this mode of transition. We talked about digital data. We talked about where we were coming from. But how do you, many of you have already gone through the different systems out there, maybe 2 or 3. And you don't want to go through that learning curve again. So this is actually designed where we've actually had clinicians pretty much up and running within 30 minutes. Mm-hmm. And they're doing complex notes within the hour. When I say complex, I mean very complex notes. It can be 10, 12 pages long. Thank you. And all they're doing is tapping. And as Jody mentioned, as you're doing it, we're using algorithms and to generate the note for you. So you don't have to sit there typing, dictating, waiting for it to go off to transcriptions, then come back, you correct it, then go off to billing. It's all done for you in virtually real time. And I know you're all going to ask about, what about the coding? Well, if you see that arrow right at the top, what we've also done here is taken the Medicare's correct coding initiatives and converted those into algorithms, because we've got the data now to apply to generate the correct code for you at a RAC auditable level so that you don't have to do it. So by the time you've completed your patient visit, the patient is with the physician. By the time that encounter is over, the note is done, coded, and ready to go off to your billers and
right.
coded off to the payers.
And let me add that it's natural language. We also have light machine learning, light ML. This is natural language processing. If you were to type in some words or speak some words, it's there. It's flawless. We have so many people working with this now, and it's true. It's done in real time. So before the patient may even get dressed, put their shoes on, and walk out the exam room, you're done just as they're done. It's ready now to send it out for billing. And there's more. Go ahead, Kishore.
So what does that mean for you? What does that mean in this environment? Well, let's go back to our original mission, right? So we've addressed now the ease of use. We've addressed the ability to how to capture that binary data in a very easy manner. And we've also applied algorithms so that you can auto-document and auto-code. This is that 60% that you saw on that slide earlier of the physician burnout. Spending so much time on the physician, the clinician burnout. So consider that left-hand side documentation and coding already done, automated, and you've actually captured the data. So if you are one of these larger clinics or health systems that wants to apply things like AI, you can amplify your AI now because you've actually got the raw digital data.
And let me jump in as you're mentioning AI, if I might, because that pairing is actually ideal. AI is trained data. It takes a while to get it trained. Whereas ours, the binary, it's instant. So you put them together, the amplification is really something, and is something we're looking to add, partner going forward. But I also want to add here that we are connected to many registries, and so this automation includes prescribing, labs, it's all in there. It's not just your record, but now separately you have to do these things. It's all part of that flow.
And that's actually another interesting point there, because Jody, in this COVID environment, you know, we had entities coming saying, we need this data and we need it rapidly. And most data is historical. It's 30, 60, 90 days out. Here, we could give that data in real time virtually, allowing people like the CDC and other entities to make more informed decisions. So it comes back to the data again and the ease of capture.
Right.
So what do we do then for this? So you've now got the data for actionable, you can action, you know, so you can now, if you're doing clinical quality measures, we all know that in clinics and health systems, it's only in this value-based care, you know, you're going to be on performance, and did you do your A1Cs? Did you check if it was a smoking status, etc. All of these things can be pushed into your quality measures in virtually real time. So you've now got actionable data. And here what I mean is that, let's say, for example, you've got a clinic, they're doing their quality measures, and they're analyzing it at the end of the month or at the end of the quarter. Well, you know, that's good that they're doing it, but sometimes it's too late, because going back to the clinicians then and saying, hey, you need to do this, this, and this, you've lost the opportunity during those days. Whereas if you go back to them the following day, hey, say, you know, you didn't do this, and if you did this, it would increase our scores, our measures. And so you got a behavioral change happening in this digital, you know, highway that is coming along. You've got to, it's not just about capturing the data, having the actionable data, but how organizations, staff members, including clinicians and physicians, have that behavioral change in a slow manner to adopt the new 21st century that, you know, of healthcare, which ultimately then leads to increased in revenues. So I'll just share a couple of these metrics which we are now seeing in clinics. We're seeing a 30% increase in productivity on average. Some have actually claimed even more, but just say on average, you're seeing a 30% increase. In fact, the more complex condition the patients are in, i.e. the higher the acuities, the more productivity gains they're having, just, you know, they're seeing. This could translate into an increase in profitability, or, as I've spoken to many physicians and clinicians, they would just like to have more free time, right? It could be translated to dollars, but it's amazing, Jody, they just want their time back.
Sanity. Well,
Yes.
That's the burnout piece we're addressing right there.
Right, absolutely.
Yeah, exactly.
And then you've got, because you've got the data and you're auto-documenting it, you're actually now coding correctly for the services you've provided. Many clinics out there, in fact, most clinics, undercode because they're afraid of audits, and they're leaving at least 15% on the table. And whereas we can automate that for them, you know, IQ can automate that for them. And then obviously on the right, this translates to, you've already mentioned it, you can have the, you know, the billing and everything done even before the patient gets home.
Right.
So that's reduced accounts receivables, which is a reduced cost of capital, which is a reduction or redeployment of admin and staff to other tasks. And a recent figure where we've just added on is now we're seeing close to a 99.67% clean claims on the first pass, because you've got the digital data at the front end, all the way through to the billing, the coding. You run it through more engines, you match it against the payer engines, and then you submit it, which virtually eliminates denials.
Right. And we see clients same day, within minutes. We've literally seen them scan the list and click, 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 watching them do it. It's kind of mind blowing to me to see that. And a note, because we are caring people, when we say a reduction in staff, because you don't need transcriptions, you don't need scribes, and probably have 1 or 2 people and all they do is resubmissions of the claims because they get getting denied. Keep people if you want them, but allocate them to ways that help your practice grow, help in so many other ways. So we're not just saying get rid of people, though fewer FTEs is definitely part of that.
So what does that mean now? What's the transition? People are probably going to be asking. So, okay, this may sound great, right? But I've got, I've already got an EHR, and I understand that the government is moving now forward and it's opening up. But how do I transition? Well, that's the other great thing that I believe that the government has done recently is to enable and unblock that data from these, as you were talking about earlier, it's my data, it's my turf, and nobody else gets in. So it's unlocking that. So there is an opportunity there in the market and in clinics and organizations to start tapping into that. And the way that we've approached it is to say, okay, we've got this great user interface, the ability to capture that data in a nice, easy manner. We're not there to compete or replace or anything, but we could complement the clinics that are using these different systems. So just as you may have your iPhone and connect to your banking systems, in the same way, we feel the technology is certainly there, that you could have this actually layered on top of existing systems and allow data to move up and down using now standards and protocols, which are still evolving. I'm not saying they're all there, but if this continues at the pace that I've seen the change over the last 10 months, I am absolutely sure that within a very short period of time, companies and partners and people will start looking at this and saying, hey, we can have the best of both worlds. So
exactly.
That's what we can help with on transitioning clinics, capture that binary discrete data,
Right.
have it actionable and increase the revenues, and above all, reduce that physician burnout.
Right. And I should say too, to make sure there's no confusion, as Kishore said, we absolutely are not looking to compete with EHRs. We're looking to complement them and partner with them. But we do have a complete independent software platform. But Kishore, part of his brilliance, along with the other proprietary things he's developed, he designed this in such a way that it's, I liken it to the Apple App Store, which is why I always refer to Apple. We have, let's say, the iPhone, and just as Apple has an App Store, we have a Protecsa App Store to give context. And so we can partner with and integrate with, we mentioned AI, RCM, oh my gosh, prior authorization, all kinds of things as apps. We want to partner, but we also can provide the full service today that people need. So that's where Kishore's saying we have a modular kind of a menu of options.
So this is one I know that you wanted me to put in there, Jody.
I just love the robot.
We were looking at this and we were seeing as a company that we believe that telehealth will be the new future.
Well, you did this years ago. You have to give context. This is a long time ago. Yeah.
That's right, Jody. We did this quite a few years ago. And, we did do that, and it actually went straight to Times Square because it got a lot of interest. But as healthcare being healthcare, it was very difficult because you had so many rules and regulations and state requirements and billing and everything. And we as a company decided to continue to focus our, have a focus on our application rather than the actual robotics and the robot, although it was absolutely great fun. It was great fun. But fast forward now a few years, we see telehealth, right? And it's amazing because the application that we have is as valid. If we look at the consumer market as such, patients are essentially the consumers. They want to see they want to send a text message now. They want to send, and I call it the now society. That's the generation we live in. They want to send a text message now. They want access to their bank balance now. They want to see their doctor or a physician now. Well, I kind of go a little bit further because with my kids as well. I said, well, guess what? You're going to be able to see your doctor now, but we're going to get you the documentation, and you're going to get your bill now as well. So it's all being condensed down into seconds. And combining that with telemedicine, I believe this is going to be a lot more prevalent now as clinics evolve into remote care. They want to have their clinicians. They want to be able to talk to their family members. They want to be able to, clinicians want to be able to be more preventative, and they need to be able to document all that for billing and compliance and legal reasons, which is what we do and excel in. So telehealth is here, and it's a great story. Thank you. Oops.
There you go.
All right, so you want to take this one, Jody? Or?
Okay, sure. Well, here we've arrived at the end, and we thank you for, we're not ending the whole session, but the last slide that we have. And thank you, everyone, for taking this journey with us. That's our segue now for another pun for the superhighway. And we want to provide that on-ramp to the digital superhighway, this next digital wave that I know CalHIPSO is really at the forefront of as well, and working with them to drive that. And as partners of CalHIPSO, we would like to extend what we could do with solution, service, and we've decided to come up with an introductory offer. We're offering this to everyone in the state of California, 3 months free, and that's specifically to use our clearinghouse, our claims processing service. We're not asking anyone to switch to IQ. We're not pushy. We're not, we're not trying to, what'll it do to get you to drive off the lot right now on this pretty little Mustang I've got on the lot? That's not who we are. We're hoping our benefits and qualities will speak for themselves. But we also would like to help clinics that are not yet there, also hospitalist groups who may be looking for some things with their companies, whomever that might be, home healthcare companies. And after the 3 months free, this is not a teaser bait and switch. We will then offer from that point on, day 1 of month 4, 50% off, not of our fees, of your fees that you're paying today. Because we really are very sincere in wanting to help you and make it easy, and in everything we do in our lives, right? The 2 things, you look at rate, review, is it going to work, and what's it going to cost me? That's who we are. And so we wanted to address that. So again, 3 months free for our clearinghouse, our claims processing service, 50% off, not our fees, your fees that you're paying today. And please mention CalHIPSO. That's a code. When you contact us, you can see Kishore's information and mine are below, by email, by phone, however you would like to do that. We also have our LinkedIn company page, and we're on LinkedIn if you care to find us. But obviously email is probably best. But however you do that, please mention CalHIPSO as the code. Also, I will qualify this. So many people will go to our website having seen this, and there is a contact form to contact us there too. But I will say, I joined the company, as I said, not quite 2 years ago. The company had prior branding and a different website. So what's there is about to change next week. So if you look at it today, don't judge us, because we're still in that mode, and we really want to put our time and money and effort into creating a quality product, an app to help people. So a little like the shoemaker's children have no shoes, right? Uh-oh, we better fix our own shoes. We've given everybody else gorgeous, polished, great heels. So I just wanted to put that out there.
Or it motivates us to go onto the website today.
I know. Then you can compare before and after, before and after.
Exactly.
So
I
I
do
just have a
see,
quick question coming in.
yeah, I see at least a question or two.
Sure.
Did you want me
Is
to
the
answer that one?
clearinghouse Medicare only, or does it include Medicaid by state or other payers even?
So our clearinghouse module is able to take on Medicare, Medicaid, any of the payers, commercial payers in any state. So, but we are focused on, this offer is for California only as partners of CalHIPSO. So we are able to do insurances to any payer, include, Medicare, Medicaid, and the offer is for California. Okay.
Perfect. Thank you so much. And then we do have a few other questions that came in. I'm going to pause and remind anyone that's listening that you can submit questions if you'd like via the question and answer box or via the chat. Moving on to the few that we have, what does this cost, and is it something that's affordable?
So the module, the core module that Jody explained on one of the slides earlier on the data capture, that's our core flagship product, Protector IQ, is very affordable. When you consider the upside of the increase in revenues, the time gained, and the reimbursements. It is approximately $500 per month per provider with a one-time fee of $2,500. And there is a discount for those who are part of the CalHIPSO organization and in California. So it is very affordable and very easy to implement and get moving forward in this digital superhighway.
And I'd like to add to that, having done some, some math and computations, this pays for itself incredibly quickly. We are going to launch on the new site a revenue calculator. Literally, a small practice would save well north of $1 million because of getting all that time back. You can increase your patient volume, not be rushed though. It's still the quality of care. You can see more patients in a day, going from industry average of 25 patients per provider per day, to 35, 40, 45, fully optimized. So more patient volume, more billing, paid first submission, paid faster, and cutting costs because you don't need all these people to keep resubmitting. And so we've seen it pays for itself, and I think we've estimated too, it might be around 30, 40 cents per patient, depending on what you're using from what we offer. But that's also, again, part of why I joined, to do good works, to do something where you're not selling widgets. And so it's eminently affordable.
Jody, that ties into some of your responses, ties into the other question we have is, can I keep my EHR? So, that's definitely a cost factor. It'd be fun to see your calculator that you mentioned, but I'm really right now invested. I'm expanding upon the question. I'm really invested in my EHR and all the data where it's been and all of that. So can I keep my EHR if I start doing an add-on, basically?
Well, I'm going to say yes, and I'll hand to Kishore, but we are able today, not with the full, as we think of interoperability, but we can pull in and push out data today. So we could pull in data elsewhere and push it out, but it would be great to contact us. We could give you the detail of how that works and the unstructured and structured. But I'm going to hand this to Kishore. He's really the guy to answer this one.
So yeah, Diana, thank you. So yes, the short answer is you could keep your EHR and you could optimize it and enhance it, right, with the plugin, you might say, or the add-on. And you can generate, as Jody mentioned, additional revenues just from having that application layered on. Going forward, there are going to be so many different things that are happening, I believe, in the market, which will be a great segue into some future webinars, and giving clinics and health systems even more choice and opportunities of either keeping their EHR or moving forward with their, with new products and services coming out from some really great companies out there.
Yeah, and also, just to be clear too, you can have both. As we're saying here, you can use, and that's why I referenced the Apple App Store, right? So you could use just the clearinghouse and claims processing service or solution, not the entire thing. And so that's the thing we really want to stress. And this is where we're saying we're not pushy people, but we're trying to tell you where we're going and what's possible. And there are many more things we can do. And again, we're not trying to, it's not a sales pitch, and we don't want to load up like a laundry list. Yeah. But we want to ease people on. And so you could contact us. There are other things. Perhaps you're thinking, oh, I'd rather do this one thing differently. And we welcome conversations about that. Sorry, Kishore, did you want to say something more?
No, I was just saying that I think that the healthcare industry at the moment, where it is positioned, is going through a lot of change, obviously, in the COVID, post-COVID. I think there's going to be a lot of hybrid models that are going on. I think a lot of clinics are looking at various options and the future. We've already mentioned telehealth, etc. So there is a lot of uncertainty out there as well. But one thing is for certain, that clinics have to move onto the digital highway. They have to transition towards value-based care. They're going to have to do more reporting, more compliance, more documentation, I'm sorry to say. So they're going to be looking for tools that can help them do that and still have a quality of life.
Let me jump in. Sorry, but I forgot to say it before, and you're reminding me, especially quality of life, value-based care and scoring. So with value-based, obviously, got to see improvement in patient care. One of the amazing things that Kishore did, again, the 3D peel away graphical anatomy that you may have seen sooner. I don't know, we went quickly. It's on this slide, the right-hand side. There are over 5,000 graphics. These have deep layers. So it's from your skin down to not just the nerves, but nerve sensations. And because it's touch, tap, talk, if a patient is, obviously you're in person and you're comfortable with it, you can let them touch or tap if they are not articulate, if there's a language barrier, if for any other reason they have difficulty describing their discomfort, and for better engagement, they feel involved in this provider-patient partnership with you, they can tap on things. And it facilitates educating the patient, which demonstrates better compliance. And so together we create patient and provider satisfaction in a way that, along with patients wanting to have access to their data through interoperability, there's this other component of, we all know the studies show, you talk to your patient, they leave, that's it. They don't fill the prescription, they don't come back. Because, do you want to come back? You have a follow-up visit? Did you go get that MRI?
They don't do labs.
They don't do anything. And this actually makes tremendous difference. And to be honest, I know this not from Protexa, so I'm not even claiming this as we do this at Protexa. I'm saying this from 15 years in global marketing and my own independent agency, all of my clients being big pharma, biotech, med device, and every one of these brands, it's all about education at first, right? Every provider, let's tell you all about our new drug, and every patient. But even for uptake, when they're going to generics, it doesn't matter. The only thing that gets a patient to comply is to feel like they have a voice, that they fully understand, that it's okay to ask questions, that they're participating in their care. And again, having their data is great, but the component that Kishore created is not, I've never seen it anywhere. And we do, in fact, one of our doctors has said this has really been a game changer for him in working with his patients.
All right, so with that, I think it's time to wrap up. We do 4 minutes. It was 5, but we've already clicked to 4, so we're near the top of the hour. Some people will be able to take a bio break before their 1 o'clock meetings, get water refill type of thing. Thank you very much for presenting today. Please don't hesitate to reach out to CalHIPSO or to Kishore or Jody. I'm sure they'd be willing to give you a demo. I can't give you a demo, but I can pass you to them if you need. And again, thanks for joining. Stay safe, everybody, and be well.
I just want to say thank you, Kishore and I both. Thank you to you, Deanne, to Lauren, to Lori Vance, who's helped. And I also want to make sure I acknowledge all the people working at Protexa, because it surely takes a village. Kishore's brilliant. You know, you could see I'm his PR person. I just think the world of him. And I'm glad I can contribute. But we have amazing people who work with us to make it possible. And so I also want to extend an acknowledgement of those people as well.
Thank you, everyone. Thank you. Thank you. Yeah.
Okay. Bye. Thank you.